Now I invite Sir for the talk. Also, good evening, respected senior members and dear friends. Today, I'd like to present two cases. Yeah. So, one patient, 15-year-old girl, Sanjana, she came to our casualty on 16 July with a fever for 1 week duration. Actually, she is a daughter of one of the nursing assistant working in a PSC. Initially, she got treatment from there. She didn't had any cough, chest pain, loose stools, headache, vomiting, no, any focal infection. So they did the investigation, and it was there was urine was showing pus cells, and they brought with a culture report. I think E. coli sensitive to ceftriaxone. She came for parental antibiotic and admission. Then what happened? Okay. Okay. So on physical examination, she is conscious, alert, oriented time person, place, not in distress. There is no pallor. There is no jaundice or cyanosis. There is no lymphadenopathy. Vital signs were, except the heart rate was 116 per minute, BP in 164. So she was admitted in a hospital, I think on 7th Saturday evening, with urinary infection. So what happened the next day? The physical examination was, chest examination was not significant finding. Heart were normal, S1, S2 were normally. Abdomen was, there was no organomegaly. So patient was admitted after doing investigation. There was urine was showing pus cells around 40 to 50. Even there was a culture report also. So what we did, even CBC was done. I think it's not clear. There's not much leukocytosis. WB was normal. So patient was, next day I made a round. That time, the next day, patient had sudden chest discomfort and tiredness. So what happened, then we examined the patient. BP was in the lower side, 90/60. Pulse was 120 per minute. So we did previous day, we asked to do a chest X-ray in order to find is there any why patient is having fever and so. Luckily, then next day only we saw the X-ray. Chest X-ray was showing. Somebody wants to know. There's a cardiomegaly. There is some infiltrate in the left lower zone. So, what could be the possibility? It is because patient is having hypertension, tachycardia. So we thought it's a cardiac tamponade. So because so next what we did immediately, we called the cardiology people, asked to do echocardiogram. Echocardiogram was showing this one, sorry. Cardiac tamponade, pericardial fluid with the features of cardiac tamponade, like velocity, flow velocity in the tricuspid and valve is increased. And there are other features of, there is an inward motion of right ventricular free wall in the diastole and all, suggestive of cardiac tamponade. So we discussed the case with the bystanders, because patient was admitted for other reason. It's life-threatening emergency. We suggested them to do this one, pericardial synthesis. So what? Just a brief discussion about pericardial effusion and cardiac tamponade. So virtually any disease that can cause pericarditis can cause effusion. Any disease. Actually, you should try to find out the cause for pericarditis. So there are different causes, like infective causes, like any viral infections, like viral coxsackie virus, AB, herpes, mumps, adenovirus. All these viruses can cause. Another, this one is a bacterial, like usually post-operative, pyogenic, pneumococcus, streptococcus, staph, all these organisms. Another common cause in the developing countries is tuberculosis. It can cause pericarditis. Some percentage of patients can go to cardiac tamponade. Fungal infections also, especially HIV patients, there will be histoplasmosis, coccidioidomycosis, all this can cause also. There's a non-infectious cause also. Actually, most of the cause of pericarditis is not due to cardiac non-infectious causes. Like if you rule out all other causes, you can go say it's acute idiopathic pericarditis. Otherwise, renal failure can cause pericarditis. Sometimes tumors, primary tumors, benign or malignant mesotheliomas, metastasis to the pericardium, like lung, CA, breast, and all that. In this patient, it doesn't apply. Then other causes, generally, pericarditis can be due to trauma, aortic dissection, sometimes acute myocardial infarction, post-radiation. So some pericarditis can be due to some hypersensitive reactions, like or autoimmunity, any rheumatic fever, connective tissue disorders like SLE, rheumatoid arthritis, ankylosing spondylosis, all this, even drugs like hydralazine, procainamide, and all can cause pericarditis. So actually, you have to find, our main task is to find out the cause for pericarditis and treat the pericarditis. But if a patient is having tamponade, immediate thing is you have to treat. So as you know, it could be either inflammatory, infectious, or neoplastic, or sometimes rarely lymphoma, because of the enlarged lymph nodes and it can obstruct lymph node drainage. It can lead to pericarditis effusion. Pathophysiology is there's no obvious, if there's no obvious inflammation or bleeding, the pathophysiology of pericardial effusion is poorly understood. So we don't know what is the mechanism of birth. So what's happening in the patient is there's a high pressure acting on the surface of the heart because of the fluid. It can compress and collapse the right heart. So what will it do? It can be the underfilling of the left heart. So there will be cardiac output will be declined. That's why patients are getting hypotensive and sinus tachycardia. So you have to, our task is to find out the whether the patient is having a tamponade or not. No, sometimes patient can be pericarditis or pericardial effusion without cardiac tamponade. So there will be. So there is initially there will be a compensatory response. There is an increased adrenergic tone and cholinergic tone, but it can maintain to some extent the cardiac output and blood pressure. But after a period of time, this fades and both the declines, cardiac output and blood pressure. So as the fluid accumulates, both left and right side of the diastolic pressure increases. So all the pressures get equalized because of the pericardial effusion. So as I mentioned before, there can be elevated and equal intracavitary filling pressure, small cardiac volume, filling pressure will be low. Another important thing is JVP. There will be raised JVP with characteristics. As you know, the ACV, X descent and Y descent and all. It will be very difficult nowadays. Lots of fights. Another important physical finding is pulsus paradoxus. Pulsus paradoxus actually, it is a abnormally large decline in systolic blood pressure during inspiration. Usually it is more than 10. Up to 10 is normal. But if it is more than 10, it is significant. So it can occur not only cardiac tamponade, other causes like constrictive pericarditis, bronchial asthma, or pulmonary embolism and all can cause paradoxical pulse. No, usually you have to measure to make out there is a paradoxical pulse paradoxes. But clinically also, in severe tamponade, if you during inspiration, the arterial pulse may be impalpable. That's why this why it is called it's called because this heart sound is there, but there is no pulse. That's why it's called pulses paradoxes. It's a misnomer actually. So what are the clinical features? Usually, some cases it will be preceded by pericarditis. There will be retrocerebral chest pain. It can mimic like MI. But on one thing characteristic, sometimes on lying down position, the patient might get worsened chest pain. Or sitting up and stooping, it gets relieved. Some patients may be like our patient, it's asymptomatic also. So they might combine like our patient combines of dyspnea. So another important thing is the quantity doesn't matter. Sometimes if there's a 200 ml, if the fluid develops rapidly, it can lead to cardiac arrest. Contrary, even sometimes more than 2000 ml fluid will be there, but slowly developing effusions, 2000 ml is required. So rapidity with which it accumulates is important. So sometimes 200 ml can cause cardiac tamponade. Very important to detect this cardiac tamponade. Otherwise, we'll lose the patient. On examination, patient will be normal unless it is very large. As we studied in this one, clinical medicine, sometimes there will be apical impulse we may not be able to locate apical impulse by palpation. Heart sounds could be muffled, can be, or distant. We may not be able to this one. Usually with pericarditis, there will be friction rub, pericardial rub. Once the patient develops pericardial effusion, there may not be rub, it will disappear. The famous physical finding like Ewart sign, there's usually undergraduate level you used to learn. There will be a collapse of the left lower lung and lead to bronchial breathing and increased vocal firmness resonance and all. The characteristic feature is Beck's triad. Beck's triad, it is the feature of this one, hypotension, distant heart sound, soft or absent heart sound, raised JVP. If this is called Beck's triad, then you can suspect clinically that's pericarditis. Important thing is vital signs are very important. We people, what we used to do, we used to ask the nurse to do, record vital signs. Why that patient, when she developed dyspnea or chest discomfort, personally, we have to record blood pressure. Otherwise, nursing students or something, they will record blood pressure, they will say 160 or something. Even pulse also. Vital signs should be recorded, especially critical patient, emergency rooms and all. Vital signs should be recorded by our skilled people only. So we can, if there is any doubts also, it should be cross-checked by other people. Vital signs are very important. So patient with the tamponade appear uncomfortable and display varying signs of reduced cardiac output and shock. Some the patient can have shock due to cardiac tamponade. So there can be tachypnea, sweating, cool extremities, peripheral cyanosis, and altered sensorium also, and yawning. There can be sinus tachycardia. So JVP, you have to look at the JVP. It could be markedly elevated. One of the important things in this examination of the neck is JVP. But why is this then? It's usually absent. So as we did, you should do chest X-ray. Then that will show there is an enlargement of cardiac ciliary. So this is a water, characteristically it's called water bottle configuration, but flask-like appearance. So ECG, what will you find? ECG can cause in cardiac tamponade, there can be reduced voltage, low voltage complex. Then something called electrical alternance. This is a very characteristic ECG finding in this one. So it is the electrical alternance. See the waves, some waves are, having high voltage, some is low. So usually you won't get this one. You will be voltage of QRS will be the same. But in this patient, in this case, there will be varying voltage. So this is called electrical alternance. You might get in appreciating this one. So diagnosis by there will be echo-free space. There's no point here. You can find, there is a pericardial effusion fine. So there are other features of this is pericardial effusion. Cardiac tamponade, you have to see other features like inward motion of the right ventricular free wall during diastole. So in diastole there is no filling. So what will happen? There will be reduced output. So how do you approach this one? As you should examine the pericardial fluid. So if clinically you think you can find out a cause for pericarditis, you need not do. Like, if a patient is having viral infection causing this one, if a patient is having SLE or connective tissue disorders, you need not do any examination pericardial, or patient is going for cardiac tamponade, or you have to do. So we have to do, usually predominant cell type is lymphocytes. Serosanguinous fluid is non-specific. Sometimes rarely you will get thylus effusion because of the is a rare this one thoracic duct obstruction or by neoplasm, or in cholesterol rich hypothyroidism also can cause pericardial effusion. So our concern, usually bacteria, you can stay and culture for bacteria, including Mycobacterium tuberculosis. One of the commonest causes in our developing countries are TB. Suspected TB cases, several other tests like, gamma interferon. These are the TB specific tests. Adenosine deaminase, the PCR. Nowadays, CBNAT also. These are, you can do, but sensitivity is less, but you can do these tests. Sometimes, if you are suspecting malignant effusion and all, you can do tumor markers. So, what is the approach to the pericardial effusion? If cardiac tamponade is present or threatened, based on history and physical examination, echocardiogram, you have to do pericardial synthesis. But that you have to determine by history, physical examination, echocardiogram. If it is not present or threatened, if etiology is not apparent, sometimes etiology will be very apparent. You need not do any diagnostic tests. You can clinically make a diagnosis. Like uremia patient having no cardiac tamponade, you can do. If there's no this cardiac tamponade, you can go ahead and treat because it's well known urine or post MI. You can presume that it is due to MI. Then if your effusion is large, you can consider usually it's treated with NSAIDs, colchicine, or if it doesn't respond, you will go ahead with corticosteroids. So if the patient doesn't respond to the medical treatment also, you can try pericardial synthesis. So you can do urgent closed pericardial. Sometimes they will do pericardial window. Sometimes they do biopsy also. Whenever it's indicated. So it's no definite protocol. So it's one of the medical emergency. Otherwise, if you don't detect and treat this one, diagnose, you will lose the patient. So you have to monitor also while doing pericardial synthesis. So usually urgent pericarditis is required, except some patient with idiopathic pericarditis with mild tamponade. The inflammatory or autoimmune like connective tissue disorders and all. There's no much cardiac tamponade. Or sometimes bacterial infection also. You have to do. So what happened? Actually, we were afraid. This young girl having cardiac tamponade. So we discussed the case with this one. They were willing to take the patient to another center because So Pariyaram, they took the patient to do Pariyaram. So what happened? They did a pathology. They did aspirate immediately. There is a lymphocyte. I think it's not very clear. lymphocyte predominant pericardial fluid. So they send for CB NAT also, pericardial fluid is negative. Then they send there's a pneumonia also. So they did the sputum also, CB NAT is negative. Then HRCT was done because there was a consolidation. It was suggestive of a consolidation in the left lingula and apical segment of the lower lobe. So there's a consolidation also. Even sputum AFP, fluorescent microscopy, all these things they were done. CB NAT also done, it's negative. This is the report. So it's not detected. So they discharged the patient with what they have done. They empirically started the patient on anti-tuberculosis treatment. So patient is doing fine. Patient came for follow-up and all. So what the lesson? How take-home message is: if you make a diagnosis in the beginning, you need not stick with that one. You have to. A person can have two diseases, or a patient can have urinary infection as well as cardiac tamponade. So most of the time, what we'll do, so we'll ignore this one. So very important. Another thing is vital signs. Frequent once you make a diagnosis, you should not leave like that. You have to review the diagnosis. You have to monitor the patient. As a lesson I have learned from this patient. Otherwise, if you have sometimes a sudden cardiac death, all of us, the patient can die in the ward. We don't know what is the important thing is doing investigation, test X-ray and also very rewarding also. So even though there is no symptom and all, simple X-ray test and all, you can because of the X-ray test only we did all echocardiogram and everything. That is the lesson we learned from this stuff. Any question? One more case I will discuss. I think if the time permits. I mean, we did the same day. We all gave the option whether 16, 15-year-old girl, whether patient requires some investigation also. They were not ready to get treated there. So the same day. They did. Pericardial synthesis done. So, tamponade was there. Cardiac tamponade was there. That's why patients have hypotension, sinus tachycardia. Patient is in shock. So that's why we offered them to do this one, but they were not willing. So they took. Okay. Yeah, one more case. Is this time or another day we'll do? Okay. But according to the literature, Harrison and all, 200 ml rapid. Rapid is very important. That's one. Rapid accumulation is important. If slowly, even 2000 can be accommodated. Rapid. It can happen. If it is acute one, it can happen. But books and all is given 200 ml. But most of the time it will be massive. No. So, any question regarding this case? Because another case we are going to discuss. But I think it is not projecting properly. Some slides, So another case, a 78-year-old lady was referred from our department of orthopedics on October 19. Patient presented to the casualty with a history of altered sensorium of 1 or 2 days duration. Past history, why patient is sought medical orthopedic response? She had low back pain for the last 2 months. MRI was done. It was showing. I will show the report. So then she came for follow-up. She was found because of the comatose. What happened? They brought the patient to us, referred to us medicine. On examination, patient is comatose. Only just eye opening to the painful stimuli. Glasgow Coma scale, 4 out of 50. Patient is dehydrated also, very dehydrated. Vitally, temperature 37 degrees centigrade, BP the low 164, Well, heart rate was 116, respiratory rate was 18, saturation 99%. Systemic examination was only local examination. This is the MRI. I think I cannot see also. I think you can see this one. Here it's difficult. There is a wedge compression fracture in the T10, T12, and some similar changes in the T9, T10, and all. There are some degenerative disc changes. So they thought, even a screening MRI was done. They thought it is metastasis. So metastasis in the spine. So as you know, so patient coming with the altered sensory. The law, Sanal. So altered sensorium is a very challenging thing, you know. So lots of causes, like toxins. Patients having a lot of medications, like drug abuse, usually Western countries and all, or any other medication. Poisons. Sometimes carbon monoxide poisoning. I've seen some patients, patient coming with altered sensorium. They might be in a winter season and all, they'll be having cold and all. So they can have carboxyhemoglobin, and we can have ethylene glucols. So another important thing is metabolic conditions, like metabolic encephalopathy, like hypoglycemia is one of the commonest causes. Hyperglycemia, hyponatremia, hypernatremia, hypercalcemia, hypocalcemia, a lot of metabolic conditions can cause encephalopathy. Then hypothermia also can. Then the important cause we used to find a lot of patients is pulmonary failure, hypoxemia, type 2 respiratory failure, hypercapnia, and all. They come unconscious. Liver failure also, hepatic encephalopathy patient. First time they come with the renal failure, uremia. Most of the cause of unconsciousness is not neurology, other systemic causes. Very few are neurological causes, even though cardiac failure. Then vitamin B12 deficiency, thiamine, B12. Recently, I had a patient who came with altered sensory. One pregnant lady, she's having hyperemesis gravidae. She was delirious. We suspected she was throughout vomiting. This is patient because of the vernix encephalopathy. After giving thiamine and all, she improved. She delivered. Remember, so. Sometimes vernix encephalopathy can patient present with altered sensorium. Then B12 deficiency, dehydration, malnutrition, infections. Like one of the commonest cause of altered sensorium in an elderly patient is urosepsis. Most of the time, patient coming with the UTI, pyelonephritis, and all. If you treat this one, patient will be all right. So one of the causes urosepsis. Then systemic infection, urinary infection, pneumonias, then CNS infection, meningitis, encephalitis, as you know. Then thyroid. Sometimes I have seen one patient with delirium, thyrotoxic crisis, thyroid storm. So tachycardia, and the patient has been altered sensorium. So it's a very difficult task to find out the cause for coma or altered sensorium. Hyperparathyroidism, the cause of hypercalcemia, adrenal insufficiency. These are the causes. Adrenal insufficiency also can cause. Then cerebrovascular disorders like global hypoperfusion status, hypertensive encephalopathy, all this can cause. Then another important cause is autoimmune disorders. The CNS vasculitis can cause. Cerebral lupus can cause altered sensorium. Paraneoplastic or autoimmune encephalitis can cause. Another important thing we used to miss is seizure related, like non-convulsive status epilepticus. Patient may not be. I have seen some patients. Patient may not be. Only EEG will find tell you this patient has seizures, but it's non-convulsive status epilepticus. Sometimes intermittent seizure with the prolonged post-ictal stages. Then neoplastic disorders like diffuse metastasis to the brain, gliomas. All this kind of cause carcinomatous meningitis, CNS lymphoma. There are lots of causes for this one. So it's not clear. So what will you do? You have to examine the patient. In the computer, they clear. Clear. അല്ല അതല്ല ഇത് ഇവിടെ ഇത് ക്ലിയർ അല്ല എവിടെ ബാക്ക് okay. As I mentioned before, you have to do initial evaluation, history, and special attention to the medications, general physical examination and neurological examination. Then CBC, one of the causes for sepsis, leukocytosis, electrolytes, calcium, magnesium, phosphorus, phosphorus, LFT, sometimes serum ammonia. The hyperammonia means the patient having hepatic failure. Renal function test, blood urea, serum, it could be uremic encephalopathy. Then systemic infection, as I mentioned, urine analysis, culture, chest X-ray, blood culture, ECG, ABG. I remember one patient, motor disease patient, was brought with unconsciousness, seen by two hospitals. The cause of this one is hypercapnia due to respiratory paralysis. So it is important to do ABG, type 2 respiratory failure. Then toxicology screening to find out is there substance abuse. The MRI, suspect CNS. If you suspect CNS infection, you should do lumbar puncture. Then, as I mentioned, that you should do vitamin. Is it clear? Vitamin B12, folate. Then TSH, could be thyroid storm, serum ammonia, ESR. Then immunological workup like NA, ANCA, depending upon the case. Okay. So in this patient, what happened? We asked for CBC. CBC was showing hemoglobin of 9.2, ESR was I think 60 or something. Microcytic, normocytic normochromic anemia, MCV normal. So urine was showing pus cells, numerous pus cells. So there will be one of the causes could be urinary infection, sepsis could be. Then we asked for RFT, urea 111, creatinine around 3, sodium 125. So these also contribute, but it's very rare. Uremia, hyponatremia also can contribute. This one. Then what do you suspect? Your patient is having altered sensorium, anemia, renal impairment, and he's having bone lesion. You have to suspect multiple plasma cell disorders. So we asked to do this one, LFT. So albumin was around, I cannot see. Total protein was 8.9. Albumin was 2.8. Creatinine, this one, globulin was 6. There will be age reversal. So one of the causes for age reversal is multiple myeloma. So there can be liver disease also can cause this one, but this is because of the multiple. So what happened? Why a patient is having altered sensory? So one could be due to sepsis. What other cause? Another cause, important cause is hypercalcemia. So we asked for to do calcium. Calcium was, where is this calcium? Okay, calcium was around 12.5 or something, 12.5. Blood sugar was there. So one of the contributing causes is hypercalcemia. So what are the causes of hypercalcemia? There will be excessive PTH production. Then hypercalcemia of malignancy in this patient, either it could be lytic skeletal metastasis, either breast or myeloma. There are a lot of other causes like granular metastases, lymphomas, vitamin D intoxications, hyperthyroidism, immobilization, Bill calculus syndrome. All this can lead to hypercalcemia. But in this patient, most probably hypercalcemia. We asked for serum protein electrophoresis. It was showing increased gamma globin. I think is it clear? Here it's not clear at all. Okay. Then protein electrophoresis was done. Is showing MBAT. MBAT usually immunoglobulins will be there. So what are the diagnosis criteria for multiple myeloma? One is there are different types of plasma cell disorders. One is MDUS, relatively benign. Usually, most of the multiple myelomas are preceded by MDUS, multiple monoclonal gammopathy of uncertain significance, MDUS. So this is protein will be less than serum monoclonal protein will be non-IgM will be less than 30. Plasma cells will be less than 10%. If it is more than 10%, it is multiple, most of the time multiple myeloma. Then absence of myeloma defining events also. So it is a precursor of multiple myeloma. Most of the multiple myeloma patients will be having MGUS. But only 1% per year it will progress to multiple myeloma. Another asymptomatic smoldering multiple myeloma. So also it won't meet the criteria for multiple myeloma, but it is a there will be serum monoclonal protein will be IgG, IgA will be less than 30, more than 30, more in favor of multiple myeloma. Then urine monoclonal protein will be less than more than 500 milligram. So what is the definition of symptomatic multiple myeloma? So you have to do bone marrow. It shows more than 10% plasma cell. There will be endocrine damage like hypercalcemia, more than 11 milligram. Creatinine will be, renal insufficiency will be there. Creatinine will be, should be more than, this is the criteria, more than 2 milligram. Anemia, like our patient, there can be less than 10 gram. Bone lesions, either by X-ray or PET scan or CT scan. So then it could be the screening, this one will be there. So then, other than that, independently, if the bone marrow more than 60% is also favoring in favor of multiple myeloma. So as I mentioned, so how do you investigate this patient? One is bone marrow. You have to see the aspiration and biopsy. Then you have to do protein electrophoresis as we did. Then immunofixation. You have to see what is the qualitative and quantitative measurement of immunoglobulins, IgG, IgM, IgA, and all. You have to do quantitative and qualitative. Then 24 urine protein electrophoresis or even urine also. Before we used to do Benz-Jones protein and all, but it should be 20, but it's having sensitivity of around 60%. So there can be false positivity also. It's not used nowadays. It's not mentioned in the criteria, urine Benz also. But even if you do, it should be 24 hours. Then serum free light chains, immune fixation, IgD also can cause. Then as I mentioned, to deter investigation to evaluate endocrine damage like CBC, RFT, skeletal surveys, PET scan, MRI. Then in order to assess the risk stratification, you have to do beta microglobulin. Then specialized investigation in selected patients, for amyloidosis, you should do abdominal fat examination. Okay, this is the finding of multiple myeloma cells, characteristic plasma cells. Okay. Then what happened to our patient? Patient was comatose. So we put the patient on. Patient was dehydrated also. Then the patient was put on Riles tube. We gave IV fluids. The cornerstone of the treatment for hypercalcemia is hydration. Then we gave bisphosphonate. It will inhibit the resorption of bonds. So we gave bisphosphonate, IV fluids, and steroids. It worked well. What happened? Gradually calcium came down. Patient regained consciousness. Then patient she cannot walk because of the back pain, but she was clear conscious. So calcium came down. It was 11. Creatinine also came down. Even creatinine 2.8. So it became 10. So then protein, we did immunofixation to see how the quantitative, it is qualitative. Is IgM is there, IgG is present, IgM and IgA is absent. So this is mainly IgG. Then we quantitative, also see IgG around 7,417. So very more than 3 grams. So it's important. So IgG type. Other determinations is okay. Then meter 2 microglobulin also thousands. So this is by having bad prognosis. So brief about what are the treatment options in myeloma. So if a patient is newly diagnosed, so he's having multiple myeloma defining events, then what we'll have to see whether the patient is eligible for transplant, autologous bone transplant. There are a lot of regimes, that means no regime is absolute. Like, there's injection therapy, consolidation therapy, maintenance therapy, high dose therapy, and autologous stem cell transplantation. So if a patient is not eligible for this transplantation, transplantation, you have to give chemotherapy. There are a lot of regimes. I don't want to go in details about this one. Even I don't know. These are different agents. There are 3 or 4 or 5. Our time, when we were doing post graduation, only the available is melphalan and steroids and all. Nowadays, a lot of medications are there, like thalidomide, the notorious drug which causes a lot of teratogenicity. Now, newer version, lenalidomide is oral medication you can give. Then proteasome inhibitors, bortezomib. This, I think, government supplies there. IV or sub-Q can be given. Then antibodies like monoclonal antibodies and all. A lot of drugs, but the prognosis is better. Patient can live up to in stage 1 and 6 years and all. So this is all about multiple myeloma. Thank you very much.
Thank you, Dr. Mushthaque, for the excellent and very excellent talk.
സാർ ഒരു അഭിപ്രായം പറഞ്ഞോട്ടെ സാർ. ഒരു അഭിപ്രായം പറഞ്ഞോട്ടെ സാർ. ഹലോ 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 ഒരു അഭിപ്രായം പറഞ്ഞോട്ടെ സാർ.
No more questions. Out of thanks.
We Kannur may express our sincere thanks to Dr. Mushthaque sir for sharing his clinical experiences with us. Thank you, sir. It was a nice, excellent presentation. Also, I thank all members of Kannur for attending today's meeting. Thank you.